everybody, and thank you so much for joining our second webinar here entitled Caring for Black Bodies. My name is Dr. Jifa Dordunu, and I am the co-director of the Research and Educational Lead with the Pan-Canadian Nurses of African Descent. I would like to acknowledge that we are all gathered here on the traditional and ceded territory of many Indigenous communities here on what we now know as Canada. Me personally, I am joining you from the traditional territory of the Lekwungen people here on the Coast Salish Sea. It's a beautiful day here today, and I hope that your day is equally beautiful in all ways. Today, before we get to our presenters, I'd like to tell you a little bit about our webinar entitled Caring for Black Bodies. The webinar was basically created as an educational series to highlight issues that are of importance to people of those of us walking around in Black bodies. Particularly, we want to target or address issues that the misconception of Black skin has been a predisposing factor for many diseases, and then highlight issues that are actually of pressing concern to our communities. I also would like to acknowledge the Coalition of African, Caribbean, and Black Nurses in BC for their strong support of this webinar series. And I want to also acknowledge the Sickle Cell Disease Association of Canada for supporting our last two webinars. Before we get to the presentation, just know that we do have a door prices that we will give away at the very end. So do hang in there with us. We'll announce the names toward the end. And just know that this webinar is being recorded and everybody's muted. And if you do have any questions during the webinar, during the presentations, I invite you to put them in the chat, in the Q&A chat, and that will be handled. The presenter or myself will address those questions as we go along. Without further ado, I want to introduce the president of the Pan-Canadian Association of Nurses of African Descent, Mrs. Damiola Edue, who will give us a little bit more of a background on the association and what we intend to do. Damiola, the floor is yours.
Thank you so much, Jifa, and welcome everyone. So welcome once again, everyone. My name is Damiola Edue, and I am honored to be the president of the Pan-Canadian Association of Nurses of African Descent. In the next few minutes, I'll tell you a little bit about the organization. And thank you so much, Jifa, for that introduction about why we are here today. And thanks to our sponsors once again. And thank you all attendees for being here tonight. So you're probably wondering, what is the organization about if you haven't heard about us. So we all know that anti-Black racism is a public health concern in Canada. And unfortunately, it hasn't been recognized for so long. But with the recent event, in the United States, in Canada, just right in our backyard as well, there's been increased attention to, looking into anti-Black racism as a public health concern and what needs to be done. So as nurses, we came together to talk about how we can better support ourselves. And our organization focuses on not only nurses who are in practice, but also those who are in school, nurses in policy, nurses in administration, nurses in research. Really, we want to all work together because we know we all have different provinces where we are doing so many amazing work. So we're looking for a platform to work together. And this story about PCANA started so many years ago. I won't go into this, and if anybody wants to know more about the organization, you can visit our website. But I would just emphasize here that PCANA is the result of an intentional engagement and conversation with nurse leaders across Canada. And that intense conversation started the fall of 2020. So I'm glad that we are here, 2023, all working together today. But one thing that we recognize as an organization and we value is the amazing contributions of all organizations who are members in their different jurisdiction. So PCANA doesn't in any way duplicate effort. That's what the organization is about. We want to all work together. For example, if BC has some best practices, if Nova Scotia has some best practices, how can we learn from each other? How can we share ideas? How can we share resources? And most importantly, how can we support each other to become nurse leaders? So our organization members include the Coalition of African, Caribbean, and Black Nurses in British Columbia. We have Black Nurses Association of Nova Scotia. We have the Canadian Black Nurses Network. We have the Ontario Black Nurses Network. And these 4 organizations have, existing structure in terms of being registered or having a mandate, specific mandates in their jurisdictions or in their provinces. But we also have members from other provinces who are not yet registered. So we are working together to see how we can, each province can, strengthen their capacity so that they can form that coalition in their prospective provinces to advocate for nurses of African descent and to amplify anti-Black racism work in their jurisdiction. And most importantly, to work together with other nurses across the country. So our mission is simple. We have 2 things. One, yes, we want to amplify the voices of nurses of African descent by promoting the recruitment, retention, professional advancement, and representation in education, practice, administration, research, and policy. And we also want to advocate for the health and well-being of people of African descent. And one of the activities that we do in supporting our second mission is today's webinar. So Caring for Black Bodies, it's about how can we do that better, right? And Jifa will talk more about that and our amazing guest speakers that we have today. So really our vision, we want to see all nurses of African descent, we want to see us be inspired and as well as, being engaged and empowered. Most important, like we have to be empowered to be able to be leaders in our field, whether in education, whether in practice, whether wherever we work, and lead change for equitable healthcare in Canada. We have leadership teams across the country, so you get all of this information on our website. So we invite you to do that. And I'm sure some of you are probably wondering, how can I be part of this, amazing collaboration? So one, you can join our mailing list. So you've registered to attend this webinar. We'll send more information about that. You can serve as a mentor to nurses of African descent across the country. You can serve as a mentor to nursing students. You can serve as a mentor to practicing nurses. And we have that network. So I will give you an example. The Ontario Black Nurses Network, they have a Black Nurses Leadership Institute where they have different mentors and mentees. So I happen, though I'm from Nova Scotia, I happen to be one of their mentors, and we have those connections throughout our platforms. Then you can join a committee. Today we have, listening to one of the outputs of the Research and Education Committee, which Dr. Duduno happens to be the co-director of that. So you can be part of that. You can be part of education. You can be part of that mentorship, writing things about, what it means to be a mentor, mentee. We also have like social events. All of this we're planning to do in the new year. And you can be part of the funding committee as well. So if you have any questions, feel free to email us at info@pcana.ca, or you can email our Gmail address, Canadian Nurses of African Descent @gmail.com. And we will share more information about the programs that we have for the next year. So these are our social media platform handles. So again, check our website. You can follow us on Twitter. We have an Instagram page and we have a Facebook page. So thank you so much for attending today's webinar, and I'll hand it over back to you, Dr. Duduno.
Thank you so much, Damiola, for that great presentation. And so now I'll get to our panelists for today, and I will ask our panelists, to maybe turn on their cameras, both Biba and Reve, just to, like, you just give a quick introduction of who you are. I know you have your presentation later, but we'd love to know who you are. Thank you.
Thank you so much. I'm going to start by thanking you for inviting me, for having us as guests today on this important webinar. Good evening, everyone. My name is Biba Tenga. I'm joining you from Montreal, Quebec today. And I am a caregiver to an adult living with sickle cell disease first. So my son is going to turn 35 years old in May. I am also the president of the National Organization for Sickle Cell Disease. So I just like to call myself a warrior mom. That's the name that I like the most, the title that I like the most. So I'm here in that capacity today, and later on I will talk more about it. Thanks for having me.
Thank you so much, Biba. And Reve, please, can you introduce yourself?
Hello, everyone. My name is Revea Japan. I am a sickle cell warrior as well as a stem cell transplant thriver. I currently work in the pediatric hematology clinic at the Stollery Children's Hospital that's in Edmonton. And I'm currently in the sickle cell disease nurse role. So it's amazing. It's a blessing. And I'm really happy to be here with all of you guys today. And thank you guys so much for inviting me for this opportunity.
Well, thank you both so much for accepting our invitation to be here today. And I'm going to turn the floor over to you, Reve, for you to give us a presentation today, really focusing around the pediatric population, because that is your population that you work mostly with. And we can certainly have a roundtable discussion around some of the things that are similar with the pediatric and adult population after. But in the interim, I will turn it over to you to give your presentation. Thank you.
Sounds good. Thank you guys so much for your time. So I hope you guys enjoyed this presentation. I'm going to go ahead and I will share my screen here too to go along with it. All right, we'll share this. All right. And so I mentioned a little bit about myself, and, you know, my love for sickle cells goes so deep. It is not just, you know, because of my job, but because I also have experienced sickle cells. I have gone through stem cell transplant. Honestly, you name the complication and I have experienced it. And so I'm very happy to be sharing my passion with you guys. You know, sickle cell is my main passion, but I also, you know, I love nursing in general. And I am a nurse by day. I am an author as well as I am an entrepreneur. So there's many layers. So let's dive right in to talk some more about sickle cell disease. So first, let's do a little bit of a knowledge assessment. Like, I don't know if anybody wants to either type in the chat anything they know about sickle cells, or if our guests are able to unmute at all for a little assessment.
They can't unmute, but we
Okay,
can deploy the questions to them.
Okay.
And they should be able to see those questions and respond to them.
Awesome. Sounds good. So we'll give you guys a couple of questions just to see, you know, where you're at in terms of your knowledge for sickle cell disease, how familiar you are with it, and then we can move on from there. Let's see. Should we give them a couple minutes before I start then?
Yeah, so people have added some things in the chat here. One person saying there is a mutation to guard against malaria. Is one of the responses in the chat.
Oh yeah, I see that. Okay. Okay.
I think people are a little bit shy today, so maybe we'll go on with the presentation, but we'll have more questions for you later on.
That's okay.
Oh, somebody just added that it's the red cells are sickled.
There we go.
And it is common in people with from African descent.
Awesome.
Is another suggestion.
Perfect, perfect. This is good. At least we kind of know where we're starting, and I'm happy that honestly, when people don't know as much or people aren't as comfortable coming through, by the end of this presentation, you will feel confident in sickle cell disease. So let's dive right in. To here, we talked about what we know. So what is sickle cell disease? So sickle cell disease is an inherited disorder, blood disorder that affects the ability of the red blood cells to carry oxygen throughout the body. So normally these red blood cells are round and they're flexible and they can kind of make it through every nook and cranny of your body. But sickle cells actually causes the red blood cells to change. And so they're a curved, misshapen, sickled shape. And so these cells actually do stick together and they block blood flow throughout the body. These cells can get stuck in any area of your body. They can affect the hands, feet, joints, bones, and major organs. And so when the blood flow to these areas decreases, the tissues do not get enough oxygen, and that causes pain and various other problems. Sickle cell hemoglobin is not efficient at carrying oxygen. So under certain stressful circumstances and conditions like infection, fever, or dehydration, the red blood cell can change into this rigid shape that looks like a crescent moon. Red blood cells that contain hemoglobin A live for almost about 120 days. However, cells that contain hemoglobin S only live for about 10 to 20 days before they start breaking apart through this process called hemolysis. And the result is a lower hemoglobin and anemia in those living with sickle cell disease. So I have a little diagram here. You can see what the sickled cells look like as opposed to a normal red blood cell. See, it's kind of causing a little blockage there. And this chart on the side just shows the green is hemoglobin A, and a red cell with hemoglobin A, how long it would last for and how long it would live for. And then one with hemoglobin S is just a little bit, only 10 to 20 days. All right. So now that we know a little bit about it, let's dive right into the origins. So the origin of sickle cell disease, it was first described in 1904 by James Herrick while he was caring for a medical student in the Caribbean with pain, and he said unusual shaped red blood cells. It's a very widely accepted theory that sickle cell actually evolved from an adaptation to exposure to malaria. For this reason, a lot of people who originate from these various areas in the world affected by malaria, if you see it on the photo there, the malaria belt, often are affected with sickle cell disease. So I know people like to, classify it. We always think that it's only Black people who are affected by sickle cells, but there's a lot of places where in this malaria belt, but also because people are migrating, we are moving around, we are mixing, we are mingling. And so because of that, you'll find sickle cells pretty much everywhere. Let's move on to the inheritance. So how do you get sickle cells? So sickle cell disease, it is autosomal recessive inheritance. So each parent that has to carry the gene mutation before you can get it. It's not something that only one parent would have, and then you would just have the disease. So essentially, in this diagram I have here, there is two parents. Both of them are trait carriers, so they would be AS. And then the likelihood of them having a child with sickle cell disease is 25%, so 1 in 4. The likelihood of them having a child that's also a carrier, like they are, is 50%, so that's 1 in 2. And then as well as another 1 in 4 chance of having a child that does not have sickle cell disease or trait or anything along those lines. All right. There are many different types of sickle cell disease. I won't go into super detail about them because for us, we treat all types of sickle cell disease the exact same. In terms of when they come into the hospital, they get the same management, the same treatment. But majority of people know about hemoglobin SS. That is a more moderate to very severe type of sickle cell disease. It's the most common actually form that we see as well. There's also hemoglobin SC. It's a little bit more mild to severe. So often people are under the assumption that people with SC actually don't get that sick, but it is not true because there's a spectrum. There are some people with SC who are quite unwell and more so than those of SS. Another few kinds we have here. So there's hemoglobin S with beta thalassemia. So there's hemoglobin S with beta 0 thalassemia. So that means that there is not any normal hemoglobin being produced. So they would act very similar to someone with the genotype hemoglobin SS. Then there's some other ones here. There's hemoglobin S with plus thalassemia. And so that one, they actually will get some normal hemoglobin in through their body. There's also hemoglobin SD. It's classified as Punjab sickle cells. That a lot of people from usually India will end up with SD, but anyone can have it the way we're mixing and mingling. And then another type is hemoglobin SO Arab. And so that a lot of people of Arab descent and background are more likely to have that. It is a moderate to very severe type, very similar to someone with type SS. Okay. So I guess let's move on to our complications of sickle cell disease. So I'm just going to, we're going to start with some acute complications because a lot of you guys, or maybe all of you guys, are nurses. And so I know these are things that you will see in the hospital. These are things that are going to bring sickle cell disease patients in the hospital. Okay. So the first one we're going to talk about is infection and fever. So people with sickle cell disease are at an increased risk for life-threatening infections. As we know, the spleen is an organ that serves to help filter and remove bacteria from the bloodstream, and it also helps produce some white blood cells with that. So sickle cells can damage the spleen very early in life, and the spleen is then no longer able to filter bacteria out of the bloodstream. As a result, bacteria can travel through the bloodstream in just a few hours and cause an overwhelming infection. These infections can cause shock or even death. Pretty much every time a patient or a person in general with sickle cell disease has a fever, it should be and it must be considered a medical emergency. So as a nurse, it's very important that we understand that fever can be life-threatening in these patients. It's not something we play around with or joke with. We advise all of our patients at home, if they do have a fever, not to give Advil and Tylenol. We want you to come into the hospital because you don't know what can be going on. Advil and Tylenol would actually mask it. For any other child at home, you would just, give Advil and Tylenol, but not for these ones. And so often when someone says they have a fever, we assume that the fever is caused by bacteria, and we will automatically do a blood culture for them, as well as a full workup, and start them on antibiotics even before we get those culture results. And so just remember, there should be no delay in reporting to physicians or charge nurse. The next one is splenic sequestration. So this is something that you'll see in the pediatric population. And so oxygen levels in the spleen are quite low and blood moves very slowly through it. And so when you think of the spleen, think of it as a very slow highway during rush hour on a snowy day. So essentially it's not moving very fast. And so because of this, the red blood cells tend to sickle in the spleen. In some cases, this can cause a blockage of the outflow of blood from the spleen, and then it can trap the red blood cells and the platelets. Then the spleen will swell up, and there's a rapid fall in hemoglobin and platelets circulating in the rest of the body. This is known as splenic sequestration, and it definitely is a medical emergency in our little guys. You see it more common than you'd think. It's a lot of children get it, mostly children under the age of 6 will get this, but still, you never know how old they can be when this happens. It is extremely painful. And there is just a little photo of splenic palpation. As a nurse, you don't actually need to know how to do splenic palpation, but if this is your patient, we just ask that people are a little bit more mindful of the fact that a child can have this. And so if you're monitoring them and you notice that they're complaining of left-sided stomach pain, anything like that, that's something definitely to make sure the physician is aware of, so it can be added to their management. And so if you're ever checking the blood work of your patient, and for some reason, you saw them earlier, blood work was fine, and then a little bit later, you notice a rapid fall in hemoglobin and in platelets, something that you can think of is this could potentially be splenic sequestration. And the management for this, what we do is transfusion, just to kind of help dislodge any of those cells that are stuck, as well as fluids. We give our patients lots of hydration, and then oxygen as well. The next one here. So the next one, pain crisis or vaso-occlusive crisis. So this is a very, very common one. It is the most common reason why patients with sickle cell disease have to go to the hospital very often. So under certain conditions, such as extreme exposure to temperatures, so whether it's too hot, whether it's too cold, fever, dehydration, infection, stress, all of these different things, we call them triggers, but they can cause the red blood cells to sickle. And so when patients start to see, as they grow, they'll start to see patterns that, oh, every time I'm in the cold, how come I end up with pain crisis? Every time it's really hot, every time I don't drink enough, or often when patients will play sports, they notice when they finish, because you're likely dehydrated because you're running around a little bit, as well as there might be a little bit of stress, good stress or bad stress with that. And you might be playing in the hot sun. So those are three things that already can be contributing to potential pain crisis. And so these vaso-occlusive crises can block the vessels, preventing oxygenated blood from getting to the body tissues. This lack of oxygen can be very painful, and damage to these blood vessels, it's the lack of oxygen, is painful, but on top of it, the damage to the blood vessels from the cells coming by and scraping them is also adding pain, as well as swelling in the area of the blockage can increase pain. And so there's 3 different reasons why these patients are experiencing pain and what is causing that pain. So the pain crisis is the #1 reason why people will seek medical attention, and it's often the most common reason as well why they will be admitted to hospitals for extended stays. And our treatment and management for vaso-occlusive crisis is first, of course, pain medication, fluids, lots of fluids, oxygen as well, and then transfusions. But we also try our best to use, non-pharmacological practices, like warm blankets first, if it's a child. Honestly, an iPad distraction can help hold them off for a little bit while we're waiting for medication. So older children and adults, or older children, adolescents and adults usually get their pain in their long bones. So that's going to be their arms and their legs, their chest and their back. But a younger child, the first sign of pain that they often show is something called dactylitis. So I have a photo just on the right there. And dactylitis is also called hand and foot syndrome. It is definitely the first type of pain that patients will see. To spot dactylitis, essentially you just put both hands side by side. So if a patient with sickle cell disease who's young comes in and they're having extreme pain, they show you their hand and it's swollen like this, that definitely means that they are experiencing dactylitis. Put both hands side by side and you'll see that one is larger than the other. You also want to be mindful and pay attention to the digits. So it's not always the entire hand, but sometimes a portion of the hand, maybe just the thumb or something like that, is a little bit swollen. And, I guess my nursing consideration for this one is just know that these patients don't want to be in the hospital. They're not coming to the hospital for fun. They don't want to sit in emergency. They generally try their best to manage their pain at home before they even come. And so when they're not able to manage, then that's when they decide that it's time to go to the hospital. The hospital is definitely the last resort. And so when you ask a patient to rate their pain, just please believe them, even if they don't act like they're in pain. Often people with chronic pain and chronic illnesses, they don't act the same. Pain is different. They live their life in pain. And so what you would, take as someone who's in pain, crying, rolling around, all of that stuff is actually something that it's rare to see that in sickle cell disease. They typically, keep to themselves. You might see some whimpering, some labored breathings, a little tear here or there. But if the pain is really bad, maybe you'll see some rolling, but it's very unlikely. So just something to be mindful of. Oops, let me go to the next one here. The next one is acute chest syndrome. And so acute chest syndrome is a very serious complication of sickle cell disease, and it is the second most common reason people are hospitalized. Acute chest syndrome is a result of the sickle cells actually blocking the tiny vessels in the lungs, characterized by chest pain, difficulty breathing, increased oxygen demand, fever, and changes to the lungs as seen on an X-ray here. And so acute chest syndrome can actually be caused by pneumonia, or it could be caused even from a pain crisis, because often when you're in pain, you're not able to take in these deep breaths in and out. You're just kind of getting by. You're just taking the smallest breaths, and you're often like crunched in a ball, so your lungs are not expanding. And so because of that, as well as, pain medications, when you're given pain medications, it's bringing your respiratory drive down. And so all of those reasons can contribute to why the lungs aren't opening up and expanding and moving things around as they should be. And so that can interfere with it. And so as a nurse, it's very important to encourage deep breathing exercises, post surgeries and just in general, as well as the incentives barometer. We use that, make sure that our patients, when they're admitted for a pain crisis, because you're likely not walking around, you'll definitely need something to ensure that your lungs are opening up well. And then, of course, individuals that are experiencing an acute chest syndrome, they often will need a red blood cell transfusion just to kind of drive up that hemoglobin and get the oxygen circulating, as it currently would not be. The next one here is aplastic crisis. So an aplastic crisis is caused often by parvovirus, known as Fitz disease. So it is a childhood infection that causes mild fever, cold symptoms, and a rash to the arms. The cheeks also might become bright red. And so parvovirus can actually shut down the production of red blood cells in the bone marrow for as long as 10 days. And, for most children, this does not really cause any serious problems. But however, when the red blood cells of a child with sickle cell disease don't last and live for as long, then when you shut down the bone marrow for up to 10 days, it can result in severe anemia or a drop in hemoglobin. Because the bone marrow has shut off the red blood cell production in general, there's a very low or absent reticulocyte count. And so those are our baby red blood cells. And so nursing consideration for this is just watch for patients that show signs of worsening anemia, such as fatigue, headache, extremely pale lips, nail beds. They all could be indicative of an aplastic crisis. We've actually been able to diagnose a few children with sickle cell disease because they ended up having an aplastic crisis secondary to parvovirus and were admitted to hospital, and they were very anemic and they were really sick and no one really could understand why. And then eventually someone thought to run a sickle screen, and we were able to accept them into our program and take good care of them. All right. So we have just a couple more acute complications here. I think there's just two more. So we'll just go over stroke. And so over time, sickle cells may damage the vessels in the brain, making them narrower and narrower. Sickle cells can block these and just completely prevent oxygen from getting to the brain tissue, causing a stroke, which of course we know can result in permanent brain damage. And so I think we all know the symptoms of stroke, but just in case, we will go over. So there's severe headache, weakness on one side, maybe inability to speak or understand language. Sometimes you'll even see seizures, drooping facial features, or trouble swallowing. And so it's possible that even a child can have these transient ischemic attacks and have these symptoms, and they resolve in less than 24 hours. And we actually know that approximately 10% of children with sickle cell disease, hemoglobin SS and hemoglobin SO Arab that we spoke about earlier, are at risk for suffering from serious neurological event. And the average age for a child to experience such an event is 8 years old, which is just crazy to me that is the average age that these patients are often having any type of neurological events or stroke. And so a child who has already experienced a TIA is at extremely high risk of potentially having another one, and one that could be more serious as well. And so for this reason, we will start that patient on regular red blood cells, and the goal of the regular red blood cell transfusions is to replace the child's blood, which can sickle further and cause more blockages, with a normal red blood cell of a donor. What we're doing right now is something called TCD. It's a transcranial Doppler. It's imaging that we're using on our pediatric patients. Essentially, it's an ultrasound of the head, and it's able to detect any abnormal flow through the vessels of the brain, and it will show us if there are any areas that are narrowing. And it is actually a really good predictor of stroke. And so we've been able to really bring down these statistics of stroke in sickle cell disease children. And so the last acute complication we'll talk about here is priapism. And so this is an extremely painful complication that is often experienced by some males with sickle cell disease. Sickle cells can block the blood flow from flowing out of the penis. You know, blood is going everywhere, so you can get these blockages literally everywhere. The result is a very long-lasting and unwanted erection flowing out, of the penis, and it is very painful. It definitely is a medical emergency, especially if it lasts more than 2 hours. It is really important that caregivers and health professionals, we instruct boys to let someone know when they're experiencing this. If left untreated, it can lead to the ability for a normal erection in the future. And it's a very awkward thing. It's an embarrassing thing for these guys. It's hard to talk about. And so often it can go unnoticed. Sometimes it will resolve on its own, but you don't want to keep doing that. It takes a lot of bravery and courage of a young man to be able to share with his mom or dad or health professional what's really going on. And so the treatments vary for priapism, and it can include anything from IV fluids and pain medication, as well as blood transfusions and vasodilators sometimes can be needed. And if these measures don't work, then it would have to be escalated to a urologist, and they would use a surgical procedure to release the trapped blood. It is common for it to happen again, and so we try our best with preventative measures like taking medication, like hydroxyurea, or if the patient needs to stay on a vasodilator a little bit longer term, if this keeps reoccurring for them. But that is a little bit about priapism. And so now we're moving on to the chronic complications. So there might be some people here who are taking care of more adult patients. And so these are just a little bit of background information as to all of the things that are going on in the body. We talked about things that will emergently bring people into the hospital. And then now we're going to talk about these chronic complications and things like that, that kind of are lifelong things that patients are living with. So different areas of the body that can be affected by sickle cell disease. The first one is the eyes. So we've heard about scleral icterus before, that yellowing of the eyes. And that happens because the red cells are breaking down so fast and releasing that bilirubin into the body. And it goes and it sits in the eyes. And that's one of the places that it will go and sit in. So you'll often see sometimes a discoloring of the skin, but mostly it will be sometimes pretty bright yellow eyes. Another thing is sickle cell retinopathy. The retina can be affected. The tiny blood cells or blood vessels, that flow to the retina are tiny. And so over time, these blood vessels can become blocked by the sickle cells. And so our body is smart. And so it tries to find ways to get where it needs to. And so our body will often create these tiny collateral vessels, but then often they're not strong enough. And so you can have different circumstances where blood is flowing in the back of the eye, and it can actually burst one of those blood vessels, and then you can get leaking in the back of the eye and actually a detached retina, which can be very terrible. Often patients lose their peripheral vision and different things like that. And they often don't even notice. And I can even tell you from my personal experience, I didn't know I had sickle cell retinopathy. I thought I was fine. I didn't notice I was losing my peripheral vision. So clearly there was things going on in the back of my eye that I had no clue. My eyes were 20/20. And so I figured that, well, my eyes are 20/20, then why would I have any eye issues? But no, it is not true. There are things that are going on, but I was able to get it corrected through laser eye surgery. Another area of the body that is affected by sickle cell disease are the heart and the lungs. And so we know that the heart's job is to pump oxygenated blood around the body. But people with sickle cell disease, because they have a lower hemoglobin and less oxygenated blood going around, their hearts have to work a lot harder. And as a result of that, it's very common to have an enlarged heart in a patient with sickle cells. As well as a nurse, if you're listening to your patient, it's often that you'll actually hear a murmur or an unusual sound, and this is just the result of chronic anemia. There we go. Then we will go on to the kidneys. So the kidneys, we know the kidneys filter waste out of the body. There are about 100 million tiny filters in the kidneys called these nephrons, and they remove the waste. And so the sickle cells actually can block these tiny vessels in the kidney and damage the nephrons. And so it causes urine to actually be less concentrated. And so often many children with sickle cell disease can suffer from bedwetting. And honestly, that goes up until adolescence. Some people even into adulthood. But the issue is that they're not able to concentrate their urine and hold it for long enough to then use the washroom. And so oftentimes we'll have a lot of patients that experience bedwetting. The gallbladder also can be affected. Often patients with sickle cell disease will end up with gallstones, and some of them, honestly, as young as 5. You'd be very surprised how often and how early in life it happens. And so what essentially happens is that as we were talking about these red cells breaking so frequently and releasing this bilirubin, it can also go and sit in the gallbladder, and all of a sudden you get lots and lots of backup, you get lots of sludge in there, and then they can become crystallized and harder, and then you now have gallstones. And so in a patient with sickle cell disease might come in, and so if they mention having upper right abdominal pain that just worsens after having fatty foods, spicy foods, it's very possible that they could have gallstones. And the last thing I'll talk about in terms of the chronic complications are joints. So the body supplies lots of blood to the joints just to ensure that everything, as the body is supplying blood to every other area, the joints are no exception. So what can happen in these ball and socket joints, those found in the shoulders and those that are found in the hips, is something called avascular necrosis. And so this often happens to the joints after the blood flow is repeatedly blocked by sickle cells. And so definitely it kind of feels like arthritis pain, stiffness, achiness, especially in the morning or after sitting for a while. If you have a patient that describes this type of pain or achiness, it's important when they're admitted for a longer amount of time to maybe consult physiotherapy, see if there's some in-bed activities and exercises they can potentially do to keep things moving. Because when you're in pain, you can't expect someone to get up and go for a long walk, and that's okay, but we have to at least find other ways to get patients up and moving. As well as a lot of people do actually have to get hip replacements. In pediatrics, you don't see it as much because we try to hold off. And if someone even has AVN or avascular necrosis, we try our best to manage it so that when they go to adults, then they can potentially get that hip replacement then. Just so it will be a lot larger, and then they'll be able to keep it for a longer amount of time. I have here a slide about surgical considerations. So this is just a quick aside in terms of if you ever have a patient that is going for surgery that has sickle cell disease, it's very important that you alert the operating team because they honestly might not know. If they have a hematologist, it'd be good to let them know, because these patients, we often will transfuse them before they go, or admit them the night before and make sure that they get at least 8 hours of pre-hydration, as well as provide them with an incentive spirometer, which we talked about already. And then they would need some close monitoring afterwards, because we'll be monitoring, of course, for infection like anyone else, but we know that fever and infection in sickle cell disease is definitely a medical emergency. So we'll have to watch them very closely. And then, of course, you want to encourage deep breathing and coughing exercises. making sure things are still moving around appropriately. So now on to, the bright side. Now that I've told you guys all the hard things about sickle cell disease, we talked about acute complications, we talked about the chronic stuff. Now we can talk a little bit about the silver lining, the treatments, all of the positive things that are happening in the sickle cell disease world. And so right now we use hydroxyurea as our gold standard medication. It works by increasing the hemoglobin F, therefore decreasing the sickling. Hemoglobin F does not sickle. And so before birth, red blood cells that contain this fetal hemoglobin is replaced by hemoglobin S in the first few months of life. But some people actually inherit this ability to have a higher hemoglobin F. And as they get older, we actually notice that they have less complications with sickle cell disease because their body is already doing what the hydroxyurea medication would do. So hydroxyurea is actually a low-dose chemotherapy agent, and it was found to stimulate the production of hemoglobin F. It's found to increase it, and then when it's taken and it's correctly monitored carefully, it definitely does not have any serious side effects. It's been shown in research studies to decrease the number of pain episodes and acute chest syndromes, as well as the need for transfusions and hospitalizations. It really is a miracle drug. Some people can say it does give them stomach aches and things like that. And to be honest, I've had it before. It's not the most pleasant in terms of stomach aches. You can get some stomach aches while your stomach and your body is adjusting to it. But overall, what the medication does far outweighs, some stomach discomfort initially. The next treatment here is transfusion. So we're going to talk about just a simple transfusion. You guys know, just a regular packed red blood cells transfusion is often what we do for our patients, of course, when they're in hospital and it's an emergency situation, but we also do that in preparation for surgery, mentioned, but as well as some patients come in every 3 to 6 weeks. And with that, we get them transfused for different reasons. It could be because they had a TCD, that transcranial Doppler, that didn't look too hot, and we know we just want to keep their hemoglobin A, their normal hemoglobin, a little bit higher. We'll have them on there as well. The next type of transfusion is it's a red cell exchange. We call it a high-powered transfusion. So essentially, a certain volume of your blood is removed, and then that same volume is replaced by donor blood. And so that's why it is an exchange. So some people might be getting up to 2,000 mils of donor blood, and that can be done anywhere from every 4 weeks to every 8 weeks. And this is in pediatrics as well as in adults. I have quite a few patients that need this treatment and require this treatment. Often it is because maybe we did see that their TCD wasn't that great. And so we do want to ensure that they have lots of hemoglobin A just to help them out. And this is done via, I don't know if you guys have ever seen an apheresis machine, but it is a very high powered machine that essentially is going to pull your blood out, spin out the sickled cells, takes out the part we don't want, and returns actually the rest of your blood. And then you get an extra transfusion of the regular red blood cells, and you leave feeling brand new. I personally was on red cell exchange for 7 years. Yeah, about 7 years. And let me tell you, it is life-changing. It really is. It helps so much. You feel like you can exercise again. You can go about and do things you never thought you'd be able to. Way less pain, way less complications. And so it is a great treatment. And so our gold star, I guess, the only treatment we have right now in sickle cell disease that can be considered a cure is bone marrow transplant or stem cell transplant. People talk about both. They're kind of used interchangeably sometimes. So because bone marrow transplant, although it is the cure, there are a lot of side effects and there are a lot of issues and things that can come from it. Before the bone marrow transplant, what a lot of people don't realize when they're so excited about this cure is that you actually have to have chemotherapy and radiation before to destroy your bone marrow. And so your bone marrow, where your cells are made. And so you'll get an infusion of the donor's bone marrow cells. And in the weeks and months post-transplant, the donor cells will eventually take over your blood system and start producing cells that are unaffected by sickle cell disease, which is just amazing. Lots of risks with it, of course, things like serious infection, bleeding, organ damage from the chemotherapy and the radiation, graft versus host disease, which I'm not sure if you've heard before, but essentially it's an easy way to explain it is when the donor cells wake up in your body and realize they're not in the right place or they're in a new place, and they begin to attack the recipient's body, the patient's body. And you can get lots of different complications. It can attack any area of your body, and these complications can be fatal. So this is definitely not something for the faint of heart. If you're not really sick, then it's not something a lot of people would even bother considering. But essentially, with bone marrow transplant, it is still a bit tough here because you do need a matched sibling donor for this. And not everyone has a sibling, and not everyone has a match in their family, because right now it's about 25% chance that you have a sickle cell, I think a sibling without sickle cell, and then a 14% chance that that sibling without sickle cells will also be a 10 out of 10 perfect HLA match. So it's really only a 14% chance. So not everyone can go forward with this treatment at this time. But I'm hopeful that I know there's so many different things around. There's gene therapy they're talking about, CRISPR, all of these different treatments that I know there's trials all over the States, the UK, and we're starting some here ourselves in Canada. So there is hope for our sickle cell population. So this is just a quick slide on things that have actually been heard on units that people have said about patients with sickle cell disease. So the first one here is saying, he's fine if no one's in there, but the second a nurse walks in, he's moaning in pain. This is like, people will say that, you know, this patient is faking it, they're doing this, but sickle cell pain is transient. And so they might not be in 10 out of 10 pain 24 hours a day. It might go and come and go and come. And it's not that the nurse walks in, it's just that at that moment, that's when the pain has come. Then we have the one on the right here. It's talking about how the child was just playing in the playroom, and then suddenly she's crying again. They just don't understand what to think. It's the same thing, how sickle cell disease is transient. So the pain comes and goes and comes and goes. But also we talked about distraction, especially in a child. If that child is distracted, it is very likely that, you know, at that second, their focus is elsewhere. It doesn't mean they're not in pain. It just means they're distracted. And so they might start crying minutes later. This one says, I don't know what to believe. First it's in his back, then his legs, now it's in his back again. And so sickle cell pain jumps because blood goes everywhere. So the pain and the blockages can be absolutely everywhere. And so just because someone's main problem they came in with was, let's say, left arm pain or something like that, it doesn't mean that they can't develop chest pain, back pain, leg pain, or that arm might get better and then come back later. This one is talking about how this person is able to talk on the phone and watch TV. She just doesn't want to go home. That's extreme. That's not accurate. No one with sickle cell disease wants to stay in the hospital. Hospitals suck. No one wants to be there. They've tried to manage at home, and maybe they're on the phone, they're watching TV. You have to do something to distract yourself. And then the last one here just talks about how a patient asked specifically for a 6 milligram dose of IV push. And someone is saying, are you sure he's not addicted? No, the patient is not addicted. It's actually just that patients need to know how to advocate for themselves. And so if they know that 6 milligrams of morphine pushed is what actually takes the pain away and actually works, then that's what they're going to advocate for. And that's what we encourage people. That's what I encourage my patients to do, that if you remember exactly what you took, ask for that, because there's no point in playing around with someone coming in with sickle cell crises and they're giving you Advil Tylenol when you've been taking Advil Tylenol at home for how many days. So that's just another thought. and just to be mindful of. Trust me, I knew exactly what I needed when I went into the hospital. I knew that I needed oxygen. I knew I needed fluids. I knew I needed, I knew Dilaudid worked better for me than morphine. I knew I needed gravel, IV before I took it, or else I would throw up. Like, you need to know these things, because or else, and when they don't listen to you and you're throwing up all over the place because they wouldn't give you the gravel IV because they said it's fine if you take the pills, but your body, then they're kicking themselves. And so as health professionals, just be mindful that patients are taught to advocate for themselves, and as well as their parents, their loved ones. I teach them all. Fight for what you need. And this is the last slide here. So it just talks about how we should encourage our patients, because they also need to do our part. We've talked about all the things that us as nurses and health professionals, what we need to do, what we can do. It's also important to ensure we encourage and empower our patients to do their part as well. So things like taking folic acid, which is going to aid in the production of the healthy red blood cells. We put all our patients on antibiotics to prevent serious infections. We recommend them to drink 2 liters of water a day, just so they're well hydrated, as well as avoiding these triggers of too hot and too cold. Doesn't mean you can't go on a hot vacation to Mexico. It just means that you're not going to sit in the sun for 3 hours. You can sit in the sun for 30 minutes, but then you do want to find a shaded area and be well hydrated afterwards. And too cold, it's -40 in Edmonton and our patients are fine. You just bundle up. Of course, we also want to ask patients to avoid overexertion. Some things are unavoidable, but some things definitely are. If you have a sports game one day, you're not going to book a birthday party, a sports game, and then travel the next day. It's just not feasible. Stress, it's kind of hard to avoid stress, but you do what you can. We encourage our patients to get lots of rest and, of course, attend regular checkups. And so those are just some things that you can do to empower and encourage patients with sickle cell disease, just to remind them that this is a partnership. It's not just the medical team, but it's not just the patient. We kind of come together to create the best outcome for these patients. And that is all I have for you guys. I hope you enjoyed this presentation. I hope you learned something new about sickle cell disease, but I'm happy to take any questions about my presentation, about my personal life and my experience with sickle cells. So yeah.
In the interest of time, we will move on to the next presentation, which is by Mrs. Biba Tinga, who is the president of the Sickle Cell Association of Canada. So Biba, I'm going to turn it over to you to introduce us to your organization and all the great work that you're doing. Thank you.
I think Ravi has explained it before, right? The community affected by sickle cell disease all over the world, and specifically in Canada. They come from Africa, Caribbean, Middle East, South and Central America, Southeast Asia, and Mediterranean. And of course, the most of the time, the majority of them in Canada are from Africa and the Caribbean. So there is the stigma on this community. The way we receive care, the way we have access to care is always different for the dominant majority. So health equity is needed here for us. And we need to have systemic changes in this healthcare system before people like Alvin Yulis of Petrina can live a life. And even Ravi, even though she'd had the bone marrow transplant, I'm sure she's still experiencing some of the complications that she had before. So for them to have, a life where they don't have to fight to have access to care. And I think she's explained it when she was explaining all the treatment options that we have. I want you to just picture this. For over 40 years, what we've been left with in Canada is supportive care. And what do we call supportive care? For someone like Alvin who has sickle cell disease and my own son, what they have is they have hydroxyurea, blood, painkillers, immunization, antibiotics. That's what we've had. And since the end of 2019, I don't know if you're aware of that, but 2017 was the first time, July 2017, we have the first drug specifically dedicated to sickle cell disease approved by the US FDA. Then in 2019, in November, we had 2 more drugs. So where we stand today, we have drugs approved specifically for sickle cell treatment, but they are not available in Canada yet. We don't know how many years it will take for them to get here, but we are working on it. We are advocating, trying, when we have clinical trials going on for the Novartis drug, and we hope to get them so that, because this one size fits all does not work for sickle cell disease, because have you seen, there are so many different complications and every patient is different and affected in a different way. So how can they expect for the same drugs to treat everybody? And when we talk about, the curative therapies, bone marrow transplant, one of the barriers that people face is that the eligibility criteria are really something that we don't determine as patient community. They don't consult the patient or the caregivers. The physician decide who gets to go for the cure. And it doesn't make sense. Yes, there are so many risks, but explain the risks to the patient and the parent and let them make the decision, because it's about their body and their health. So next, please, Alvin. So that's where we come in as patient organization. That's where we stand and say, we have to do something. We have to do more than just, being caregivers, more than just supporting ourselves or advocating for ourselves. We have to go to get to our policymakers. We have to also talk to our healthcare providers. And that's why series like this are very important, where we get to interact with you and talk to you and let you know. So the Sickle Cell Disease Association of Canada is the national umbrella for sickle cell disease in Canada. So it was just funded in 2012, which is like, we're just very young, 10 years old, but we've had provincial organization that was funded way before the national organization, and they've been working to support patient community on the ground. This map shows you the map of Canada, of course, and wherever is red, this is where we have representation and patient groups working on the ground. I've heard somebody from Saskatchewan, so we have to talk. Maybe we should work together and set up a patient support group there and work together. Next, please. So as I said, it was funded in 2012. So, and what we do, we are committed to increase awareness about sickle cell disease in its treatment and a method of identification, diagnosis, treatment towards improving the quality of life of individuals affected and their families. Because sickle cell, you have to know something. Sickle cell is a family disease. If one person is affected, the entire family is gonna feel the burden of the disease. The parents, the siblings, even the extended family, because it's long hospital stays, sudden crises that, unpredictable crises at a time that you don't even expect them. And also for the parents, sometimes missing work. And when you miss work, it's just, the impact on the family finances. And for that child also missing school and the long-term education, they are not able to complete their education, then to get a job and to be able to participate as any other citizen, it's really harder for them. Yes, many are able to have maybe less crises when they are on medication like hydroxyurea or blood exchange, that they are able to complete their education, but the challenges are so many. Maybe it will take them more time than others and so many accommodation that sometimes they don't also get because of the color of their skin, because that also comes on top of the chronic illness that they have to deal with. So next, please. So what do we do? The best thing for us to do as patient advocates is just to build a strong community of allies. And you here, I see you as allies, as our strongest allies, because when you walk into any healthcare facility to seek care, one of the first people that you will meet will be a nurse. You will talk to a nurse, right? She will come take your vitals. She will meet you in the ER everywhere. So I think if we are able to build this relationship and work together very well, then we are going to save life and we're going to improve the quality of life of the people living with sickle cell disease. But how do we do that? You have to know that there are systemic barriers, health-related stigma due to race, disease status for sickle cell disease. Ravi explained it, the socioeconomic status of people who are affected, our community. And, having this chronic and acute pain that needs to be managed with opioid, that Alvin explained it very well, how they look at you, how they don't believe you, You saw how they say, oh, she's on the phone, she's talking, but then, you know, she doesn't want to go home because she's still in pain. Recently, a young lady died in the United States, and she was able to record it when they were telling her that, point blank, that the hospital did not want her. She had to go home. And she was saying, I can't go home. I'm still in pain. It's all over. If you type on Facebook, you will see it. There are so many people talking about it. And she was sent home and she passed away, unfortunately. So not being believed, not receiving the proper care. That's what we face every single day when we go seek care for ourselves or for our loved one. And the lack of knowledge, we have to recognize it sometimes that most people do not know how to care, you know, for sickle cell patients. So I found it very disturbing when a sickle cell patient present, and I will give you really an example for my son. Last year, he went into a crisis, sudden crisis, and he was complaining about stomach pain. And he was literally lying on the floor. He was so much pain. We tried everything. I said, maybe it was food poisoning. Then we started painkillers. It didn't work. I ended up calling the ambulance and they took him to the ER. He ended up having surgery for a testicular infraction. Most physicians have told me in Canada that they've never heard of such a complication. They knew, but like they've never had one. They've never had to treat one. But one of the things that they did, I made sure that they took him to the very hospital where he was receiving care. But yet nobody contacted his hematologist. So he went straight into surgery and ended up being sick for almost 4 months. Do you know why? Because they did not follow the protocol that Ravi just showed you. He was supposed to receive blood. He was supposed to be hydrated. I know it was an emergency. They couldn't do all that, but they had just to call his hematologist and make sure that he was aware that that young man was in the ER for a surgery. They didn't. And that almost cost him his life because it took him 4 months to get back on his feet. So if you don't know, ask, look into the patient file, connect with the physician or a nurse who has treated sickle cell patients. That's why we asked you in the beginning. It's very important. So that's why what Pecan is doing today is life-saving for our community. And we couldn't just miss it. We had to be here, Alvin and I, to come and share our stories and our information. So if you're not always willing to listen to the patient and you're not also wanted to do the proper thing to connect with the physician who are treating those patients, so how are you going to be able to care for them? You know, now, one of the barriers also that we think is the time. Physicians have told us over and over that if you see a patient coming to the ER, through the ER door with a sickle cell crisis, that patient has to receive care within 30 minutes. Nobody has been able to get that in Canada. Never. The minimum that they will spend will be 3 to 4 hours minimum before they even get any type of fluid or IV or even see a doctor. So how can that work? They end up staying longer, you know, and then they're already in crisis because know that before they come, they will have tried everything they can to control the pain and hydrate at home on their own before they show up. So if the maximum waiting time is 30, so if you know that, if you see a sickle cell patient, just try to give them the care as fast as you can. It's not putting them on as a priority on top of other patients. It's because their own case is different. That person who came with a broken finger, it's going to heal quickly and go back to normal life. Not a sickle cell patient if you don't give them the care. We even went as far as giving them a card that was signed by the hematologist. That was something that we tried in Quebec and in some part in Ontario. So saying that this patient has sickle cell disease, please give them care. But they never did. They told us at the end, I showed them everything, but they don't even, the nurse doesn't even look at it. So how can we do that? How can we change things? Now, are you an ally? Listening today, can you become a strong ally? To do so, this is what you have to do, to recognize the systemic health inequities the sickle cell community has been facing, you know, that we are still facing today. Understand also your role and position of privilege. Advocate for change. Don't just do what everybody has been doing. If you know that it's wrong, don't keep quiet, raise your voice, treat your patient right, you know, and then get the training, you know, because it's very important that if you acquire the knowledge and the expertise, then you can do better, you know. and adopt all these practices that we are talking about. I'm just shocked that everywhere you go now, they're talking about, anti-Black racism, best practice, inclusion, diversity. But yet, we've seen no change in our community, none. So something needs to happen. And then research, do some research if you can, and that's one of the things that is very important for the Sickle Cell Disease Association of Canada. We are creating, a lot of opportunities for research to just have the data that we can use to better advocate for our community. And then finally, as I said, be ready to stand and raise your voice when needed. Be respectful when treating the Black body, please. Be respectful. Now, what else can you do? If you happen to be someone who can donate blood, that's something that we need. As I've said in the beginning here, we rely on hydroxyurea and blood. Those are our two treatment options for the past 40 years. So we are always looking for people from the same ethnic group to donate blood. And some of you here are from the same ethnic group as the majority of the patients. So if you can, donate blood. What we've done, we have a partner for life number with Canadian Blood Services. When you register on blood.ca using this number, every donation you go will be then attributed to sickle cell disease. So the number is there, very simple, take an appointment and donate blood. If you can donate blood, advocate for it. If you know people around you who can do that, please ask them to donate. And another thing that you can do also to support us so that we can support our patient community, next, please, is to support us financially. Any donation is good. You can commit to $10, $15, $20 a month or a one-time donation. We are a charity. And once you go on Canada Helps, I will have Alvin drop this link in the chat so that it's easier for you to copy and share. You will support. This young man is a young warrior who lives in Ottawa. His name is Micah. And his mom wrote a superhero book because him and his brother both have sickle cell disease. So I met him because he's a young advocate and we went together. We do go together to talk to the policy maker to make sure that, sickle cell disease is a priority on the federal government agenda. So thank you so much for your time. I hope that if you ever have to see a sickle cell patient now, you will treat them differently and you will understand how, to care for them, how to better care for them. And I will leave you with this quote that I really love. I read it and I'm like, yeah, this is the type of nurse that we want to meet every time when we go to seek care. Thank you.